starting? All right. So, thank you very much, everyone. I think we'd like to start. We'd like to start now on time because we'd like to end by 8 and then allow some time for questions and a little bit of a networking time after the event. They'd like us out of here by 9 p.m. All right, so first of all, I want to say thank you for everyone who came, actually, because it's always easier not to do the thing than do the thing, especially when it's raining outside. So thank you for everyone here. And then after that, immediately, thank you so much, Othman, for hosting us and for providing this lovely venue and the catering. Hopefully we can get to do a lot more events here. Yeah. So for those of you who are not familiar with the MIT Club of Northern California, so we're about 14,000 MIT alums in the area, and we've got about a 50% membership rate. So and we're the largest conglomeration of MIT alums outside of Boston, not surprisingly so. This year, what happened is I was looking around and I thought, there's been a lot of work in virtual care since COVID. It's here to stay. As a matter of fact, I saw a report that said it was 38x pre-COVID, and it's here to stay. So I talked to Teddy Lopez. I told him, how do you feel about doing a digital health track? And he was very supportive. And so we kicked off this track, and this is our third event of this series. The first two events, one was on chronic care AI and mental health, and we've got this delightful event tonight. And we've also got a conference coming up during JP Morgan, so that's open. We still have about 10 startup exhibit spots there. What we do for that conference is that we noticed that during JP Morgan, it's very much geared towards larger companies. So many startups want to come in, they want to recruit, they want to seek early adopters, they want to raise money, and there's no venue for them to present. So we got McKinsey to host that for us on January 8th. With a beautiful venue, with a beautiful view of the bay. And then we've got another event in February. Afsana, she's not here today, she apologized. She's going to be talking about value-based care. It's going to be an event, a virtual event with payers. In March, we've got Jason. Jason, are you here? Raise your hand. Yeah, Jason is hosting Diabetes Gone Wild and what we're doing about it. And then we've got a life sciences event in Q2. In April, we've got an event, Can We Make Money in Digital Health? Revenue Models in Digital Health, the focus will be. Yeah. And Geetha Rao is going to be hosting that. And then after that, after that, we've got a bunch of other events that we're thinking of hosting, but in order to keep the track going, we're always looking for volunteers. So if you're looking to host an event or moderate an event or come up with ideas, please come and see myself or see Jason after the event, talk to Serena. We're always looking for track volunteers to encourage people to engage with the club and to continue bringing these awesome events. Without further ado, I'd like to kick off the events and welcome our speakers. Thank you so much for having us here today. So I'll do the intros. Is this good now?
Oh, am I going first? Are you introducing us?
I'm introducing you, and then we'll go straight to the questions.
Okay,
but
great.
this is kind of.
This is spinny. I can't touch the ground. There's nothing that makes me feel like a professional lady than not being able to touch the ground. Okay.
How's this?
This is great.
Okay.
It's not only
you. Nobody's that long.
But it's very chilly. Whoa. All right.
The Marlin are very big this year.
All right, so let me start. So Othman is a CEO of Color, and he was an early product leader at Google, where he worked on performance infrastructure and client-side software, including the Google Chrome browser. After leaving Google, he founded Mixer Labs, which was one of Twitter's first acquisitions. And at Twitter, Othman was the vice president of product, helping create the company's first revenue products and grow the user base from 50 to 200 million users. After leaving Twitter, Othman co-founded Color, where he's been leading for the past 10 years. And Color is a platform for healthcare delivery, providing the technology, infrastructure, and logistics required to distribute large-scale health initiatives to diverse populations. Othman holds degrees in computer science and management from Stanford and MIT, and he's a long-term investor and advisor to leading companies such as Pinterest, AngelList, Slack, Instacart, GitLab, and others. So, welcome. And Claire is Color's Chief Product Officer, leading the engineering, product management, data, and design teams, developing the company's population health platform services and technology. She joined Color from Optimizely, where she was Chief Product Officer, building enterprise-grade experimentation and progressive delivery products. Claire has been a founder and CEO of Experiment Engine, acquired by Optimizely, as well as a product leader in electronic arts throughout her career. She holds a BA in American Studies from the University of Texas at Austin. And I'd also introduce myself. So my name is Hesham Younis. I'm also an MIT alum. I've been in healthcare for 20 years. I started my first 10 years in radiology. I spent a lot of time at GE internationally. And I moved back to the US in 2014, and I've been working on chronic disease management since then. At first, I was at the hospital, Philips Hospital at the Home, where I launched a number of digital health programs. And then I moved to the West Coast, where I've been working for a number of startups. And most recently, my startup, Verbal, is working on virtual care quality assurance. And I'd be happy to tell you more about it at the break as well. So with that, I'd like to start the topic. You know, Othman, when we started speaking, there was 3 topics that we wanted to cover. And they're all things that I didn't expect from what's historically or traditionally been a genetic testing company. So Othman, we picked out 2 of the 3. The first one, evolving standards of care. And there's a big program with the NIH that you're working on called All of Us. We decided to hold off on that one till a further event in the springtime. So hopefully you'll host us again. We'd love to talk about it.
And if you want to talk about it tonight, Alicia, Joe over there, who's also an MIT alum, is the PI, the co-PI at Color for the All of Us work. So if you're interested in that program, FB and grab her.
Terrific. And the other 2 topics which I thought were interesting, and we're going to focus on today. The first one's around specific point solutions that can be made super abundant. Today, for example, it's very scarce to get expertise to see, for example, if you've got a mole and to know if it's bad or not. And we want to, you know, what Othman and the team have been working on is that specific take can be massively scaled and be made more abundant. So interactions with expertise and management and judgment. And the second one is around workflow and logistics that today are still highly human mediated. And what that means is, for example, if you have high cholesterol, the decision of getting on a statin is not rocket science, right? Or if you just turned 35 and you need a colonoscopy. And today, it's a straightforward logic gate that today is highly mediated through a care model, which it beats access. So these are the 2 topics that we decided to focus on. I'm personally very excited to get started and deep dive and know what you guys are working on and what led you into that direction. But with that, I'd like to kick it off and maybe start with you, Othman, and share insights into your background and personal interest in healthcare. What makes you most excited about your field? What have you learned at the intersection of healthcare and tech? And what did the 2 fields not know or understand about each other?
It's a long, big question. So I'll pick and choose what I feel like thinking about it on that front. But like, I think, you know, I don't know how many folks here have a, you know, engineering background and you know, move into healthcare at some point. I think one of the things that, you know, I feel like has been a journey that I feel a lot of other folks that are at different phases of that, is that I think when you come from, especially like an efficient market where there are a lot of engineers, like, you know, like web software, like things like, you know, whether it's consumer internet, et cetera, you're used to a very kind of like efficient market where, you know, if you build it, they will come. Like, you know, you make a product, if it's great, there's a clean way to access buyers and sellers, and the market like metabolizes progress well. And I think one of the things that is very different in healthcare, and for a lot of reasons, so it's like it's almost one of these, it's not a judgment of healthcare, it's just more, I feel one should have more zen observation of it, is that it is a much more complicated market where, you know, there's multiple parties to decisions about how care is delivered, right? Like, you know, between the patient, the doctor, the health system, the payer, regulatory, incentives. And I think that complexity just like makes it much harder for technology and, innovation to just make it into the market. And so I think that distance is much longer, and I think oftentimes we tend to ignore like the high order bit of what makes a product successful. I feel in healthcare is almost never the technology in many cases, which is very, I know all of us nerds really hate that, right? Like, but I think that's the reality of it, right? Like, it's oftentimes, it's like the market access is the most costly thing and the hardest thing, and that, so I think that's kind of, I feel like, part of the journey that, a lot of people for the tech background going into healthcare, I think, really take a while to experience, and so that was kind of like, I think, a big part of the, journey. But I think what's exciting right now, I feel, and really informing a lot of how we're thinking about the evolution of color and opportunities ahead is really when you look at different transitions, like now in this kind of generative AI wave, it's for sure overhyped in some ways, but also very likely underhyped in the long run. And what makes it, I think, particularly interesting with healthcare is that so much of healthcare is about highly structured reasoning that you want to do with high quality in a very high scale. Like, you want doctors to be highly trained, but do things in a very predictable, reliable way, almost like airline pilots. It's like high scale, but you want it to be as close or like tightly controlled in terms of quality. And I think right now it's kind of like we're getting much closer to being able to have like really high quality black box reasoning that over time I think can start making it into products and services in a way that really changes the fundamental cost structure with which you can deliver services, and how abundant you can make them. And so to me, that's the kind of most exciting thing right now.
Okay.
Okay, you gotta reread me these questions.
Okay.
What's my job and my passion? Okay, I got it.
I did not really I didn't even follow the directions
No,
there.
I'm a
but I do
rule
have a follow-up.
follower. I'm a rule follower. So, as mentioned, I'm our Chief Product Officer here at Color. I get to lead the technology organization, so that's very fun. I'm neither MIT nor have a long history in healthcare, although 3 years, you really go through the ringer, you know a lot. But I am extremely digital. So, and I think of my role here at Color as threefold as it relates to, in particular, generative AI and bringing it to healthcare. I think first, I consider myself the keeper of the corporate infrastructure around Gen AI. And I mean that in a technology way and in a culture way. I feel responsible for both enabling the company with technology, as well as cultivating the education, the culture, and the talent that can enable us to use these tools, because I might disagree. I think it's underhyped. I think it's solidly underhyped, even though maybe there are pockets where it feels overhyped as a builder. I think the second thing that I'm really focused on is how do we ensure we're creating the world that Othman is talking about, which is high quality, highly predictable, but honestly highly available and affordable care across a pretty broad surface area that has high impact. And we really believe that some of the most basic things around screening, prevention, treatment are really lend themselves to that model. And then the third thing that I really focus on is innovating on patient experience. I think one of the fun things about coming with a technology background into a interesting, challenging market is that you kind of come with the freedom to reimagine what an experience could be like and how it could be delightful, how it could be engaging, how it can be accessible, and you're not constrained by the concept of a health system or a doctor's office. And so I think that's really fun. It's a great application, both mission-oriented as well as just intellectually interesting application of technology. And so that is what I focus on here at Color.
I'm going to take you up right at the end of that, because the patient experience one is, we actually have a group exercise for my team this weekend, and we have every 2 weeks we have an all hands. At the beginning of all hands, we have a question that we go through, and this week's question is: describe your most pleasant or not that onboarding experience, whether it's from healthcare, whether it's from other industries. And also, if you've got a story about a nightmare on onboarding experience, share that too, so we know what not to do. And I'm really intrigued by you saying that you've actually managed to bring that, or you feel that you've managed to bring that onboarding experience to something that's more pleasurable. Because in healthcare, everything is kind of obstacles, reimbursement, paperwork, getting pre-authorization, and then getting on the system, and then all this other stuff. So explain to me how the patient onboarding experience worked or was working, and how you made that better with technology.
Yeah, so I'm actually, I have this fancy title, Chief Product Officer, but I also dive down and get into the muck. So I am the PM of our intake process. We call it Project Clipboard. It is our idea to reimagine, like, when you go into an office and they literally hand you a clipboard and they're like, fill out this stuff. That is the front door to healthcare, and people have that mental model. We know people have that mental model, but we want to make it as seamless as possible. So what we did is we really thought about how to make that process of gathering basic patient information, payment and insurance information, demographics that could help us deliver higher quality care, and convey the value of our care products in that process, so that people were set up to get a robust set of care. We had the information we needed about them, and it took them no time. And so we did it's a user experience behavioral design process where we really prioritized for ask the minimum amount of information, provide context on why you're asking it, be really thoughtful about the order that you're asking it in, and do progressive display of information that's secondary but not critical. And we revised our intake process, and now I know it takes sub a minute for, I think our P90 is like sub a minute completion. Create an account, fill in your information, give us your sex, date of birth, any demographics, and get into the flow. So I think it's pretty good. It could be better. I was saying the best onboarding experience I've had recently is anything that does phone-based auth, like the sort of my username is my phone number, my password is my 2FA, it just gets you in the door so much faster than I think email-based and coming up with passwords. So that's my best. Worst onboarding product, and this is process, and this is when you know you have product market fit. You put me into a Discord to access your product. Mid-Journey, you make me go into Discord with all those alerts. Like that, it's a nightmare, but I climb the hill to do it anyways because the product is so good. So that's what I would say my least favorite onboarding is.
Yeah, I feel like I jumped the gun a little bit, but you're talking about patient experience, and I wanted to touch upon that topic. Back to Othman, actually, I want to rewind here because, for me, when I saw what you're doing, and suddenly you're more than just a genetic testing company, and you have this redesigned healthcare model that you're talking about, and you've added a services wraparound about it. So when I was looking at your website, I was like, oh wow, you get my lab results, and now I have a blood pressure meter in the kit as well. Why have you decided to take that on? And frankly, there's thousands of digital health companies. I mean, you heard one of our events where we're even questioning, do they even make money? Right, yeah. So why have you decided to take that on, and why do you think you can do it better than anyone else?
Yeah, I mean, it's a fair question. I mean, I think really maybe I'll walk you through the kind of a little bit of the evolutionary path there, and time will tell whether our current approach is the one that makes sense. But I feel like really where we started off is, it's like, there's this one thing that you do that can inject a lot of signal into the system, right? Like if you use someone's genetics, you have a lot of prior probabilities on a bunch of downstream events, like your likelihood of different various forms of cancer, cardiovascular disease, how you metabolize different drugs, and you're like, okay, this actually gives you a lot of signal that you can imagine will have a lot of derivative benefit, if it's actually used well. Where what took us a while to learn was that, even with that signal, it doesn't exist it's almost like that, if a tree falls in the forest, the tree fell in the forest, there's someone's genome got done, but the doctor doesn't know about it, it doesn't interface with the pharmacy, etc. It doesn't really intersect with their experience. And so where we kind of working backwards over time, started to almost vertically integrate, and almost progressively, over time we built a 50-state medical group. So we actually, Color has a medical group that we are able to fully kind of run care programs ourselves. We built our own lab. We built a lot of logistics. You know, the end-to-end experience. It's almost like the kind of Apple model of like you end up vertically integrating sometimes out of necessity. And I think the basic bet that we're making is that we came from a world where, in many ways, I think actually like potentially this kind of generative AI, you know, cycle now is going to be a very big part of this like evolution. But I feel like we came from a world where, you know, societally, the way we thought of healthcare is like we choose this very small percentage of our population, and we invest a lot of money and time into training them and putting a lot of state into their heads, so that they understand, you know, medical practice, and we call them doctors. We further invest in giving them a lot of tools, and we put all those tools into a building, and we call that the doctor's office or the hospital. And that becomes the kind of like how we organize around administering care, right? That in a non-digital world, that totally makes sense, right? Like it's kind of a specialization of labor and, you know, specialization of you know, investments and so on. But with, you know, technology, not all of healthcare can be made distributed. Like, you know, if someone needs to have, you know, brain surgery or, you know, a knee replacement, like you know, we were talking earlier about, you know, the Da Vinci, like a robot for surgery, but like, you know, pretty much like there's still a good amount of healthcare that has a fundamental physical component, but when you step back, there's a lot of healthcare that has no fundamental reason to be physically coupled with you, with a location that is separate out of your life. And for a lot of that healthcare also is oftentimes the form of care that can be, where the marginal cost can converge to close to zero, right? Like, you know, and where the cost of non-access is very high societally. Like most people who have cholesterol don't know they have high cholesterol. Most people who know they have high cholesterol don't manage their high cholesterol. But in reality, getting tested for high cholesterol is super cheap. You know, and it can be done at home. The clinical judgment around, oh, you know, your cholesterol is at X, you should get a statin, is like
No-brainer.
basically it's not AI, it's like an if statement, right? and statins, you know, work pretty well, and they're cheap enough you could put them in tap water almost. And the, you know, like, so the marginal cost of managing cholesterol or high blood pressure or, you know, a lot of cancer screening, etc., you know, there's no reason for it not to be able to really converge to very low, like both financial as well as transactional cost. Like the other side of the coin cost in healthcare, I think, is also the cost to us to access care, right? Like for a woman to go get birth control, or for you to kind of manage your cholesterol, etc. Like the cost of you going and taking time from your work and going there, etc. That's also a very high cost that also causes people not to do stuff, right? Like, and so, so big picture, I think, like really for us, like I think the arc of opportunity, I think that we're kind of pursuing and trying to be part of is really that. It's like there's probably a slice of healthcare, and again, it's like it's not all of healthcare, but a slice of healthcare that should really be basically feel free
Right.
and be kind of ambient. And it's not like, I think, you know, there's a lot of excitement around like wearables, etc. And I think part of the imagination around that is because of that freedom of it and ambience, but like a lot of true healthcare is still kind of like contained in a way that doesn't, there's no fundamental reason for that. So
I have one thing also to say about that, which is this physical coupling of healthcare to time and place means that it's really built, the logistics of it are built around the provider and the health system, not everyday life. And so there are actually time access issues. If you work, like my dad does, delivering UPS packages like Santa Claus from 7 in the morning till 8 p.m. at night, Monday through Friday, sometimes on Saturday, when are you gonna go see a doctor? If you have mobility issues, if you don't have a car, if you don't have a ride, if you can't get around, how are you going to go to a hospital? And then if you don't speak a language, how are you going to connect with a provider, especially when we have such limited supply on great high quality clinicians? And so those are actually the kinds of problems that I think technology can really collapse, and we can do Sometimes they sound not thrilling from a software perspective, but they're so impactful from an access perspective, and they really open the aperture of who we think is a potential telehealth client, and who we can access and by what model. And I think that is very important because there is an equity and access angle to this that I don't think gets talked a lot about in telehealth, but I think the work that I'm most proud of at Color is we're really focused on that.
So walk me through the logic of you on where you decided to start. So there's many things. You could do hypertension, diabetes, cardiovascular disease. And I saw that what really attracted my attention when I was researching you guys and what you've been up to lately was the TelePrep program. So is it easier to own like a niche of a test that you've like conquered it because you've got the best testing or the best logistics or whatever, or the best false positives, and then build the service wrap around that versus the other way around, the digital health company trying to get into the testing space? That's question A. And then question B is, which disease states or conditions or chronic conditions have you decided to go after with that in mind?
Yeah, so I'll explain our TelePrep program. We work with CDPH, California's Department of Health, to deliver sort of virtual access to TelePrep and TelePrep, as well as enroll people in participants in public access programs that provide that service for free.
I think we need to tell them what TelePrep is, because you and I take it for granted.
It's HIV prevention medication.
Yeah.
And so if you've had exposure or risk, you can get a Color medical clinician within 24 hours. There's actually a time-bound aspect to when you can access this medication. You get on-demand access to a provider that can both prescribe you a first course of medication and enroll you in a program that provides that ongoing medication, including ongoing testing and medical consults for functionally free, sponsored by the state. This is one of those things that, again, the protocol is not a generative AI complex ML model. It is an if statement. Yet,
Trademark that.
the TelePrep program has, in California to date, been distributed in physical locations, so in community clinics or by providers. So you have to go to this kind of Google Map style thing. You have to look up a provider. You have to call the clinic. You have to hope they have an appointment, all this stuff. And this telehealth access program both brings the clinical availability to the home of our participants, but it also provides a privacy aspect that this particular population is really finds very important. And because Color's done such work in public sector over the past 3 years, we are translated into 13 languages. We can provide this with medical translators. We can actually provide it for deaf and hard of hearing patients. So we can access a population through our technology that many of the community clinics absolutely cannot. And then we have the operational and non-clinical care aspects that can coordinate all this on behalf of patients. A lot of paperwork. Fingers crossed AI can do this someday, but it's a lot of paperwork, and so we can coordinate. And the reason we picked this is, one, we've had great partnerships in departments of health, and we've done great public sector programs. They knew we could deliver these large scale programs. Two, it is a basic protocol that just needs to be made more accessible. And we knew we could do that with the combination of clinical capabilities, digital capabilities, and logistic capabilities that we've built. So it's a really, and I think we take that lens to basically everything we look at. Should this be more accessible? Should it be cheaper? Is it almost an if statement? And can we apply our technology, clinical, and operations platform to it? And we found a couple really high impact health areas to cover.
Okay. So TelePrep's one of them. What other disease states did you decide to go after with this
Well,
model?
look at your little A-frames on your table. We're doing early cancer screening and detection. So a lot on cancer we did, and then we have our genetics products, and then we still do some telehealth programs on behalf of very large state departments that we're proud of.
Actually, maybe Scott, just like thematically, I think one of the things that's kind of interesting with a lot of these is almost like coming from a view of healthcare where you have like these kind of functional layers, like you have all the doctors in one service and all the, testing lab, it's Quest or, et cetera. You have your, pharmacy, your medications from one place. It's almost like this kind of like functional layering of care, which again makes sense, I think, in a more physical world. But for individuals, like our lived experience is like, I don't go to Quest as an activity, right? Like that is not something I do as a person. Maybe a few people do that, but like, that's not, but like what we do is like, for example, someone had like HIV exposure. You are currently in the use case of managing that, or you might have high cholesterol. That is like a use case that cuts across a bunch of different layers. And I think thematically, like that kind of like depth first, like way to look at care, I think is kind of interesting. That like made no sense in a purely physical world, but becomes much more possible. Like if you're, like for example, our cancer program, it's like connecting. It's like if you think holistically about managing cancer for prevention, early detection, and so on, like you want to, merge the functions together into that like continuum so that you're experiencing a non-broken, non-disconnected set of layers. Like your doctor is not separate from like the pharmacy, from the lab. It's like, literally when people are on our program, it's like you scan the QR code. Actually, like we just actually launched, so we have a very big partnership with the American Cancer Society. And so they just, for example, so lung cancer is the highest mortality cancer in the US. It turns out, that obviously a lot of it is due to smoking. We actually have an incredibly effective tool to, reduce cancer mortality, which is kind of catching it early through low dose CTs. There are guidelines, but there's only 6% adherence to those guidelines. So very low adherence. If we could get those people to follow those guidelines, it would literally be a bigger impact than any cancer drug that has ever been put on the market in the history of cancer, like in terms of survival impact. And the ACS just revised their lung screening guidelines. And so we launched with them a free national service where literally anyone in the country can like go click this URL. They answer 2 or 3 questions that your doctor would ask you if they were trying to figure out if you smoked enough that you need to have, your low dose CT. If you do, it takes like you go through Claire's amazing sign up flow that makes it very easy. And then from there on, like the same service finds places where you can get scheduled, and our medical group does the referral, so that to you, what you experience is literally you answered a few questions, and then it's like, okay, here are a few places where you can get your lung screening. You choose one. You still have to
sit on the phone and book
we
it.
fight with insurance,
Yes.
and then you have to show up, right? Like, and so taking all of those layers out of people's experience, and so the person with the experience is like, oh, this is the thing that just takes care of my lung screening, and I'm not exposed to all the crap that we are all used to in healthcare. So that's kind of our hope, I guess, with this kind of model.
That's very intriguing, and I'm wondering, going back to the first question that you answered, is that, it turns out that with healthcare, it's not always the technology that wins, it's actually overcoming the barriers in the system.
Mm-hmm.
And you just mentioned an example here, well, 2 examples where I think, I'm sure the technology is great, but your
Top
wraparound
tier.
around it is
It's
not
amazing.
technology.
Really good.
But your wraparound around it is what actually improved accessibility to people using it.
Yeah, exactly. It's kind of in some ways like some of the like biggest feats of engineering that we've done. Like we've done amazing things in genetics, but frankly, like some of the highest impact things have been like simple web design or like an SMS interface.
Yeah.
That like makes it easy for someone to to get something done. But still, the hardest part is to deal with the business model of all this stuff.
Yeah.
Exactly. Well, we're going to go to business model soon, but I wanted to make sure that we covered the technology part. So we spoke about the barriers between technology and market access. We spoke about the care delivery model and how you're revolutionizing the patient onboarding experience. Now, I really want to go deep into the precision medicine piece. So we've been hearing the words AI and precision medicine and tailoring treatments to different people with genomic profiles. I'd love to hear more about that and what you're doing in that space.
Yeah, that's the nerdier department.
Different kind of nerd.
So I think like in some ways precision health has been like this word that's been used a lot, for a long time, and frankly, honestly, is one of those places that I feel has been overhyped and has underdelivered. In part, it's not for fault of the raw science. I think like, amazing science has happened, right? Like around, identifying risk for people, understanding how people metabolize drugs, a lot of the work that's going on now around like early cancer detection and so on. I think the one way to think about it, and actually, I think one interesting thing that's actually maybe we'll probably come back to it on the generative AI side of the discussion, but I think one of the most interesting conceptual promises of the precision medicine world is that a lot of healthcare interacts with us like in a very low feature sense, like in a like the analogy I use, like if we're portfolio theory, how like if you're trying to match like a risk return profile and you only have like 1 or 2 stocks to work with, it's really hard to have like a close match to kind of what you're trying to achieve. I think what the promise of precision medicine is like, you kind of can use a lot more of the available data, whether it's genomics or personal health history or social determinants of health, et cetera, to much closer match the return and reward profile. It's kind of like, okay, we have this amount of money to, and resources we want to invest in people's health, and we want to get as close as possible to the kind of like the frontier of that, that trade-off that we're trying to make. I think the term precision health got really kind of connected to just the precision matching of therapies and
Right.
and patients, and obviously that area has I think has gone the furthest, just because like that's where there's a lot of money, right? Like, and especially in cancer, right? Like when you have a cancer patient, you're going to spend a lot of money. There's a lot of therapies, oftentimes like that have very small patient panels, and you want to have like a as close of a match there. I feel like unfortunately that's like, I think a very important use case, but it's like a almost like if you were to stack order the social health opportunities, I think it's pretty far down the stack. Like we were making this huge investment for a lot of people that we probably could have saved a much better job than matching them with a better therapy at stage 4 for stage 4 cancer by getting that detection to happen earlier, right? Like, and so understanding risk earlier, et cetera. So I think that's, in my mind, like the real precision medicine that I hope ends up happening is really that side. Less like wait until people are broken and then use extreme precision to take the best shot. But like, so I used to be on the board of the American Cancer Society, and like, the thing that's kind of striking is like, you look at the last 20 years, late stage cancer survival has not improved dramatically. There are a few like specific things like therapies that, work remarkably well, but like they're very narrow, right? Like, but most like stage 4 cancers are almost as deadly as now as they were, 10, 20 years ago. But we are way better now at catching cancers earlier. We have better tools, and we are way better at survival for early stage cancers, right? Like, a lot of early stage cancers are not a death sentence anymore. And so, so like, I think that's, to me, that's really what it should be about. So.
Well, it's clear with your company strategy.
Yeah,
That's what you're
and
following
obviously
as well.
I'm-
That's right. Shall we keep questions to the end so that we can, I'm
Just
hoping
seemed
to.
appropriate to the, what I was going to interject, I've had a long history of also involvement in genomic screening, medical devices. What about prevention before, particularly in terms of the chemically induced, environmentally induced cancers?
Yeah.
Because there's a discussion with, there's such a low level of patient participation actually getting cancer screening.
Yeah.
Today, even genomic screening of their cancers. That we get a better bang for our buck if we went after the additional chemogenic, toxigenic substances in the environment. The lung cancer issue,
Yeah.
where we know about particulates,
Yeah.
not just smoking.
No, like, yeah, 100%. I mean, it's kind of, that's the, by far and there's like, I think it's almost like, yeah, the further we go up in the chain, I think the return are so much higher. I think the further we are from like today's pain, I think the more like almost like political and social discipline we need. And I think that's, yeah, like 100%. I mean, like, smoking cessation, like literally actually, right? Like if the last 20 years of cancer mortality reduction, it's not therapy, right? Like smoking cessation is the thing that has moved the needle. And the only other thing that has nudged the needle is we made the Affordable Care Act. Like we are better covering like screening, so we're a bit better, but we're still not that great. at screening, but like, yeah, no, but like by far it's like,
The 2 zip codes with the highest lung cancer incidence.
Yeah.
Are areas where they're getting exposed to high particulate levels.
Yeah.
From auto exhaust and asbestos from brakes.
Yeah.
Yeah, and I'm gonna tee you up because we were actually just talking about this, and we were making these jokes that a lot of these rules are an if statement, but these screening guidelines are brute force and trying to optimize across a very broad population for cost and outcome. And there are these very specific data points that don't get asked. How many people get asked, what's your zip code? And what does that mean for your health in your doctor's appointment? If you get asked about lung cancer, you get asked if you're a current smoker, and if you say no, do they ask if you were a previous smoker? Maybe, maybe not. Are they trying to zip you through 15 minutes? They certainly don't ask about environmental exposure. And so we've been actually playing with this idea of a new type of model, and I wonder if it's worth just teeing that up because it is relevant to the topic.
You're really opening Pandora's box.
I know, I am, but it's just like, it's
I've been
extremely
trying to be
relevant.
disciplined about, okay.
but so this, yeah, there's this thing that like we're, very early stages of working on and and it's really still very much at the idea stage and early prototyping, but the core concept that is that today we're operating with a very kind of like low resolution way to reason about, decisions and guidelines, right? Like, we say, okay, women should start getting a mammogram at 45. And then we have like 20 years of research and maybe we'll, it'll be decided, it's like, now it's like, 42. And in reality, right, like it's not like, and this applies to everything, right? Like it's not like, breast cells are hanging out on your 45th birthday. They're like, all right, like, so the cancer party's starting. Like, in reality, it's a distribution and we're making a trade-off, right? Like, there's decisions like, okay, well, this is late for some people and it's early for others. But it's a very low resolution decision where, mainly we use age and gender as the primary determinants. But like, your example about, lung cancer, right? Like, we primarily use smoking as the signal, but there's a lot of environmental sources.
30% of people who don't smoke.
Yeah, exactly, right? Like, and so for whether it's like, the asbestos cases, like different work, like, so for example, if you were a steam fitter, you have elevated risk of lung cancer, right? Like, or firemen that have like direct exposure, right? Like today, those are not put into guidelines because it's the way we think about guidelines is that we try to design an if statement that is simple enough that we can scalably distribute it to medical providers. Like it's a rule set.
So by the time a woman discovers she has breast cancer, she's been percolating for 8 years.
Yeah, so like you have.
How do you get back? So it was 45 that you should have been.
Well, so
to get at 37.
yeah, and the reality is like there's no certainty, a priori, but like the resolution with which we assess risk is currently very constrained generally to a very small feature set that I think ties back to the history of healthcare, right? Like that it is individual doctors who got trained like 20 years ago, and they need to remember this like if statement for 20 years, or 40 years as they're practicing. And there's an assumption of very low resolution feature set that we're using, as well as an extremely slow update cycle, right? Like it's really hard to roll out updates into the heads of 1 million doctors. And so this thing that we've been thinking about, and many times there's a lot of the connects to all of us work that Alicia and her team are leading is, I think if guidelines disappeared, and aliens showed up and had all of our technology and our science, and they're like, oh, how can we keep these humans healthy? They would not come up with guidelines. They would like have a great machine learning model that is able to incorporate all these very diffuse feature sets that are available, right? Like like where you work, historical exposure, even a picture of a person is a very cheap data set that can pull in like ethnic related risk. Like for example, Black men have high risk for prostate cancer, right? Like that you don't need to do something hard. You don't need to sequence them. It's like a picture. You can get that kind of signal. Or like if you have light skin, evidence of sun exposure, right? Like your skin cancer risk can be assessed very differently. So there's all these like sources of signal that are extremely cheap now and highly available that today that don't even show up in how we think about healthcare. And we think that there's a really interesting opportunity to build, what, like the future of guidelines, which is not guidelines, from a kind of truly machine learning based approach that really incorporates all the signal and the science that we all have, right? Like there's tons of studies that, that study individual populations, et cetera, that today don't even show up in guidelines, but that's real signal that's just sitting there and never used. And so that's an example of something that I think is really exciting. And a lot of the tools are here to start building things like that. Obviously, it's always harder to do them, when I just wave my hands and talk about it.
But it's a huge statement, because if I were to look at you 5 years ago and you were a genetic testing company, and now you're telling me that it's much more genetic testing, it's environmental factors, it's risk factors, it's age, it's race, and I can put all that in a machine learning model. And by the way, your response on precision medicine was that it didn't deliver what it delivered. So are you telling me that the genetic testing model portion of the whole thing is kind of minute compared to the overall picture? Is that what you're going with this? And is that how you're going to adjust your go-to-market going forward?
No, I'm actually a big believer in the value of genetics. I just think it is, from the very beginning, one of the things that attracted us to genetics was that, oh wow, it's like a very high signal data source that in reality should become very cheap to acquire.
Okay.
Because when you step back, genetic test, the marginal cost is like $100 now, right? It's not that much, right? It's less cost than having you sit in a doctor's office for 20 minutes, and probably generates much more signal about your risk. If you had only one of those two, you probably actually could, doing a genetic test and having you fill a questionnaire, your aggregate signal is probably much better than just sitting with a human and chatting for 20 minutes.
Can we keep questions just because I want to stop at 8, and then we want to have some time for networking. But we're almost done with the technology part. So we talked about ChatGPT and Gen AI and all these great things. And Claire, I wanted you to maybe tell us a little bit about insights into the development of Gen AI and its applications in healthcare and where you're seeing it.
Yeah, I mean, it's really interesting. I think that there are there's probably 3 generally accepted, very obvious applications of generative AI tools. There's deep R&D and drug development and discovery. There's a lot of interesting stuff happening there. There is clinical operations,
That's what we're
efficiency,
working on.
quality, consistency, all that stuff. And then, as I said, there's patient experience, and could there be new types of interfaces? Could there be new types of experiences that can be delivered? And then the one that actually, I'm going to add a bonus one, which is what will health systems actually look like from a size, scale, staffing, cost model when more work is being picked up by technology. So I think there's just very interesting models. You see a lot of the startups playing in the clinical operations space. It's the note transcribers, it's the quality QC.
Yeah, that's what we're doing. Yeah.
It's there's probably a great market in eFax, Gen AI intersection. I mean, that's where you print money in healthcare, is in the fact side of things. So I think there's a lot of applications. The one, what I love about Color is we stay true to the thing we're trying to do for a patient, is just get them easier access to healthcare that ultimately makes their health better and in some cases saves their lives. So we're not precious about, we have to hashtag AI everything in our product suite. But I do think there are places where there are micro delivery of delight. I can guarantee that every clinical note is going to cover the exact stuff I want it to cover. It's going to share the exact repository of content. And we make that very low lift on a provider perspective. That's an example of something that's really efficient. The brutal part of healthcare is the administrative side. Nobody in our organization is dying to attack that stuff. So as much as I can take that off the plate of a team, the more we can be creative, the more we can focus on patients. I think all that is really beneficial. So I think there are a lot of applications. Now, which applications are going to be venture scale applications, which applications are going to consolidate into solutions, which ones are going to be ingested into the EHRs, who knows? But I do think it's quite interesting to watch, and it's even more fun to build right now.
And that's kind of been our take on it as well at Verbal. We decided to go that route. So you talked a lot about the patient experience. We're very much focused on the provider experience because we've noticed that health coaches, nurses, physician assistants, all the people that would do these virtual care interactions, and by the way, there's 7 million of them now. And you talk about virtual scribes, the virtual scribes are really focused only on the physicians, so the 1 million of them. What about the other 6 million people that are doing these kind of healthcare and care navigation things? Well, first of all, they're very dissatisfied in their jobs because they got a lot of admin work. I've never heard one of them tell me, hey, I love writing notes after the call. Everybody hates it, right? Everybody hates it. And the second thing is that their job's very monotonous and lonely. So, they get on a call with a patient and another patient and another patient, then, well, when do you get your feedback? Well, we got 2 answers. Either no news is good news, or I get a one-on-one session with my manager once a month. Well, that's not good enough, right? So at Verbal, we use Gen AI to precisely attack that problem. And what we've seen, and we've got customer testimonials on our website that show you that one of the big things that they feel is employee satisfaction. They actually enjoy their jobs more now. So with our checklisting capability and quality assurance at Verbal, they're actually competing against themselves. One of our customers actually told me, hey, this reminds me of John Wooden of UCLA, where he is giving spot feedback to the players. And that's what Verbal is doing for our employees. So I was very comforted by that. So that for me is a major application of Gen AI. The other application that I have to admit is it also helped me prepare the questions. And actually, Othman had a very neat idea. It's like next event, we're just gonna have bots talking to each other, and we'll just join the audience.
That's perfect.
We can train it on like talks that we've all been part of.
I mean, this is a very San Francisco thing to say. My husband was sending me progress updates on trying to create like a bot replica of himself, and he's like, it's not getting it right. Help me prompt. So we're working on it.
All right, so I do want to stop in 10 minutes so we can take questions. And one of the reasons we get a lot of attendees is there are a lot of aspiring digital health founders here. And I want to shift the next 10 minutes in closing towards the go-to-market aspect and the commercial aspect of it. So this next section is about the learnings and the aha moments. Reflecting on pivotal moments and key learnings in your journey with Color, where you said, hey, I really came onto something, wow. And then with Claire, I have the same question to you, where either it comes to a process or a patient experience or a product that you developed and like, whoa, this works way better than I ever dreamed. So what are your aha moments with Color, guys?
I mean, I think probably the first like aha moment that was kind of like a aha with kind of like like down, like even more realization was kind of like, that really kind of at some point when we built the best like germline genetics product on the market. It was literally at the time to get a similar quality product 20 times more expensive. So we launched at $250. Every other lab was doing it at $5,000, and it was all online, included genetic counseling for free. You could talk with a genetic counselor within 48 hours, whereas normally in clinic it takes like, I had mine done at Stanford just before starting Color. It took me 6 weeks to talk with a GC, and we built like a truly like great product. And it was so hard to get in the market. And you're like, normally you expect that when you do anything that's better and literally 20 times cheaper, that you clean up. And it's like, and for a while it was like, oh, we're doing something wrong. Like it's a problem with the product. Like we should, fix this on the product and stuff. But at some point you realize like, literally the kind of incentive system, is not conducive to actual true cost savings at the system level. Like, the key stakeholders that, between the payers, like /TPAs, PBM, and the health system all make more money with costs going up. And I think most people think that insurance companies are in the business because like, that's one of those like, actually, I remember when I was at MIT, I literally remember checking out this book that was called Thought and Language in Action by this guy, Alan Hayakawa. He's like a linguist. And had these kind of like, it was about, his book was about propaganda from like, just like, but it was like, it put into your mind like this realization that like language choices and concepts are different. and the word you choose to put on something can be very different from the reality of it, and it really messes with people's minds and sends people in a very and I think it's very much a case with the things we call insurance in the U.S. are actually not in the business of what we associate with the word insurance. Like when you think insurance, it's someone who is a tool for collectivizing risk and cost between us. Like, we don't know who, but one of us is gonna have a car accident or have cancer or whatever, but we're pooling our money, and there's a whole set of assumptions around cost reduction and around et cetera that are tied to that tool. And in the US, like the things we call insurance are really not insurance. They're like transaction processors. They're like, United Health Group is closer to Visa than it is to, a company. They make more money on the flow, but they also get to be the marketplace, right? Like it's kind of like they're Visa plus Bank of America plus Amazon, right? Like literally, right? Like they're the bank account, they're the rails, and they own the service. They're the biggest employer of service providers, right? That is the current state. How to fix that, I do not know. But I think that is like the nature of like figuring out business models that try to work. But it's like realizing that is the environment that healthcare operates in.
Yeah.
You just described
And
an
it's-
monopoly.
Yes, exactly. And I think one of the biggest, and as a consumer tech person, it drives me crazy that like the FTC is spending all this time, stopping Microsoft from acquiring, Activision, or stopping Facebook from acquiring Giphy. But like, 20% of our economy is, and I think it's in part like because insurance is like, it's not completely concentrated at the kind of insurance level, but it's like very locally concentrated, right? Like there's all these local monopolies, and you have all the monopoly dynamics, and that's extremely destructive, right? Like, 20 cents of every dollar we all make goes to that, and the value we get is probably a fraction, right? And both human cost as well as financial. So anyways, it's kind of, I'll stop.
No, but that actually goes back to your first point, where the very first thing you said when we started this was like, it's not about the technology innovation, it's about how to figure out how to navigate in the business model of the current.
And that is by far the hardest part.
That's by far the hardest part. So that's your advice. Go figure out who's going to buy it, when, how.
Yeah, and
fast.
it's like I think figuring, and honestly, like it is literally still of everything we do is the hardest thing, and it's like, and I think it's the case for everyone, like who's technology and healthcare, right?
Yeah. So Claire, what's your aha moments? And,
Yeah, so as I said, this is my first rodeo in healthcare. Before this, I was in the blissful sphere of enterprise software, where the market is much more rational in many ways. But and I remember, caller called me and said, I don't know about health tech, but it was 2020, and it was mid-pandemic, and I had 2 little kids, babies, and every time they spiked a fever, I was supposed to go get them tested, and there was no tests. And the process to get them tested, I would call their pediatrician and I would say, my 18-month-old has a fever, can you get them a test? No. I remember like almost in tears driving my kid to urgent care at 8 p.m. at night on Market Street, being like, can you give my baby a test? Not like they could do anything about it, but can you give my baby a test? No. Finally, my pediatrician called an order into one of the hospitals, UCSF, for the next day. Then I went the next day, and then I stood in a room with a whole bunch of people trying to get tested for COVID. And I waited an hour in line, and then a nurse went like this to my kid, and then 3 days later, I had a test result. That was my experience, and a bill. And like that was my experience as I had the time, I had the money, I had the energy to get this very, very simple healthcare service, and I could not get it. And so I remember a caller called and I said, I'm not sure right now. And I was walking around my office, and there were these kind of like these little pop-up tents. We had these cards, and there was like one at my library, and there was one at the farmer's market, and all the moms on Facebook were saying, do you know you could get a test for color same day? Do you know they'll give you the results same day? And so I went to the website, and the registration process took 2.5 minutes, not the 1 minute I got to now. But on my phone, one hand, baby on the hip, one hand, registered, same day appointment. The appointment is literally a 1/10 of a mile from my house. It's at the farmer's market in my neighborhood. I put my baby on the back of my bike. We coasted downhill. I mean, if we're telling how story, like low friction, we coasted downhill.
Both ways.
I pulled into Color's COVID testing site, and truly that was like under 2 minutes. But I didn't have to take my baby on the bike. They swabbed. I did not coast back, and then I had to do the San Francisco thing. This is why I have an e-bike. I hoofed it up the hill, and literally that afternoon I had my result, and I was like, this company has collapsed a healthcare transaction in a way that like I had just never experienced before. And I think a company that can do that in a moment of high urgency with a team that really cares in a public sector setting that really matters, I was like, there's something special about the company. And we came here and we just did that over and over and over again in very, very high impact health areas. So that was the thing for me. It was like I had a before and after, and the after with, we should put me on the website, the after with color was just so much better. And there's a little technology in there, but really it was kind of bold thinking about what that experience could be like, and then just taking the mess behind the scenes.
That's terrific.
So why don't you end, both of you, with the advice to aspiring startup founders?
I don't. So this is I've been a founder a couple times. We actually went to dinner last night. And we were talking about the basically the dumbest website we've ever made, and his was actually high quality. But I've done it a lot of times. Some good, some bad. My advice is like, don't lose the fun in it. Things are very hard. You operate in a monopoly. Like it can be very frustrating. Market access can be very frustrating, but I always tell my team, I'm like, we have the funnest job in the world. We get to like manifest our ideas into reality and hand them to people. Like what a privilege, and like what a fun way to spend your life. So I would say like in moments of challenge, don't lose how fun it is.
Yeah, that's great.
We always remind ourselves of that, like when there's an incident or something.
At 2 in the morning.
2 in the morning.
Yeah, my team got to see my PJs last night. It was very fun.
But I think I totally agree with Claire's point there. I mean, I think just another kind of additional thing I would maybe throw out is, you know, I think it's, and I'm also saying this to myself because I'm very bad at this, but like like in general we have like, you know, big and exciting idea of like what's at the end of the rainbow and big ideas, etc. And what I feel like the companies that have tended to do best, I feel, have tended to be ones where, okay, you're excited about what's at the end of the rainbow, but, you know, how do you reduce it to, you know, to a first step of something that is actually itself, you know, a threshold of value and can serve people, you know, directly now. Because I think sometimes like it's kind of like if, you know, when you're explaining how this thing is going to work, if you say if too many times, you know, it's like a sign that like, you know, it's like, okay, like, you know, too many stars need to align for that value to happen. And so it's like, you know, and it feels very tactical sometimes where it's like, oh, I want to do something really amazing and big. And it's like, this thing feels very mundane. But I think even, especially now with kind of the generative AI world, like I think there are going to be a lot of like amazing demo apps and things that like make you dream. But it feels like the things that oftentimes really do well early especially are ones where there's like, you know, a very like almost like a very reductionist use case, and it's like, you know, because every individual user needs to individually go over the activation energy, right? Like if you're giving like sub-activation energy to 1,000 people, you still don't have a user, right? Like you have a lot of people who are like, you know, curious, but none of them are users. And so like, you know, figuring out what are the, you know, small n that you can really, you know, push through over the activation energy, you know, to really launch your product. And whether it's enterprise users or consumers, I think that's it's not only a healthcare thing. I think it's in general.
I think that's great. So I'll add my perspective, and then we can open up the question. So I think if I wanted to distill that down, is make it easy, right? And Claire's make it fun. And I'm going to add one from my experience, which is ask for help, right? So I've seen it way too many times. You get a startup founder that's, or even sometimes it happens in research, like, I'm so secretive about my stuff, I'm not gonna ask for help, or I'm not gonna share my equity or whatever. We've actually gone entirely the opposite direction with Verbal. My co-founder and I, when we ask for help, we have consultants all the time, and we give them consultant equity. So we need help with reimbursement questions, we go there. We need help with insurance questions, we go there. We need help with a product expert in an area that we're not familiar with, we have an expert to talk to. So seek help. And this whole rich or king debate keeps coming up again in Silicon Valley. I mean, there are very few kings. It's Mark Zuckerberg, and you're not going to be Mark Zuckerberg, right? So that's the bottom line. So you can be rich, but ask for help, make an easy product, and have fun while doing it. All right, that's all. Let's thank the panel. So just one last thing before we open it up to Q&A. We're very, very grateful that you offered us this lovely venue and that you accepted to be on our panel. And we ordered these lovely moleskin
Oh, thank you.
notepads from the Coop. And I hope you enjoy them.
Thank you.
Yeah.
Thank you.
Thanks. All right, questions?
He gets the MIT club.
They both have it.
But I have, this is hook 'em horns right here.
All right. Can we take someone else first? Yeah, Ronnie.
So Othman, I was going to ask you to perhaps finish that story you started about the genetic screening test, the first developed test of color, and you launched it. It was lower cost, right, higher value. But how did you actually bring it to market and commercialize it? If you
Yeah,
could share
so,
a little more there.
there are many chapters, but initially, literally, again, this is like knowing nothing about the industry. We're like, actually, the first cycle was like, let's make it available to everyone. What's the easiest thing is like, we didn't have a go-to-market team really, so we just put it online as a direct-to-consumer, where people could just pay it out of pocket, and that's why initially that price point, it was right when there was the craze around the Vitamix. And I was like, it has to be cheaper than a Vitamix. And it was just kind of like and I think the Vitamix was $300 or like something like that. And it was like, that's it's not cheap, but enough people can have access, and then we push it down over time. So that first cycle, when we started off as a direct consumer, like the challenge there is like the customer acquisition costs. It's like, through digital ads and through this, et cetera. Like we did a lot of marketing, and we got decent usage, but like it really was one of those where like there's a early like a highly high intent market that's pretty small. Once you exhaust that, the cost like goes up exponentially. And that's why, for example, like all the direct consumer testing companies haven't done that great, like whether it's 23andMe or non-genetics as well, is because I think there's like a supply of high intent people. You exhaust that, and then the cost, like you go up this cost ladder that's very steep, because there you're trying to create intent. And at the end of the day, even though we're excited about genetics, it's not like it's not a Vitamix, it's not an iPhone, as much as we'd like it. After that, we kind of started building a traditional clinical go-to-market model. So we literally we're like, oh, what are other genetics companies doing? So they had like a sales force that like go to doctors' offices, etc. And then we understood, oh, that's why they charge $5,000. It's not because the sequencing is expensive. It's because you have this army of people that are going and like buying coffee and showing up with sandwiches to the doctor's office, and like it's like, and you're like, oh my god, like you're just supposed to order a test for your anyways. But we started, we built that, and we started competing on that front, and it was we actually built a really good team around that, and they're like fundamentally, if you have a $250 product, where you're not like it's like where you're not like we had better COGS than everyone else, but the total margin dollars were much less just because we wanted to make it highly accessible, and at some point we realized like both the genetics, both the direct consumer as well as that, we're not going to be a good business. Like maybe we could make it viable, but like and that's why like a lot of diagnostics are so overpriced. It's actually cost of sale and market access that's expensive, not And so the fork in the road was like, okay, should we suck it up and become a diagnostics company in the traditional model, like take up the price to finance? And we're like, we still want to go after population. We're a population health company. And so that means a large N, not a high price thing for a small N. And so we literally did a big reset. Actually, I remember we were in this room when kind of sharing it with the company, and we did a big reset on the team, and it was a very kind of challenging fork, but it was one of those where we literally stopped being a direct consumer and stopped being a clinical sales company. So we started building an enterprise sales company. So we're like, okay, we started selling to big employers and institutions that have a higher alignment with costs and outcomes, and really aiming at that as kind of we felt that was the right kind of buyer where you can reduce the marginal cost of sales enough that you can support a highly accessible population model. To be honest, I think that is still a hard model. It is still very expensive. And so, but over time, that's where we started more vertically integrating, is doing it specific, just if the product is a test, people who are buying population health solutions are not in the business of buying, they don't want to buy knickknacks, they want to buy specific items, they want to buy outcomes and solutions. And so that's where that led us to start more and more vertically integrating, is you want to sell solutions. If you're a big employer, if you're like a Walmart or whatever, you don't want to be buying tests. You want to buy two things. You want to buy less cost of cancer and better outcomes, right? And the question is, how do you get closer and closer to selling that, rather than oh, here's my test and here's my telehealth visit appointment thing, right? So that's been kind of the
You're competing in a system in the United States that was built and is built on getting reimbursed for treating acute diseases. And I would love to hear if you could wave a magic wand as to how do you change the system from being how do we keep people alive a little bit longer and not dead, and turning that actually into a health, so that, I'll use the term personalized medicine because I still come from I prefer it to precision, because my dad still delivered me and put about 150 stitches into me before the age of 10, because I was an active kid. So I prefer personalized medicine, because it seems that with the kind of AI/ML that you're capable of with genetics, and I did genetic testing a few times over the last 20 years, and it was a lot more expensive then, and thank you for getting the price down. But you have the opportunity there to actually help people figure out what they're going to do. And one, just as an aside, one case it was, you should stop taking that low-dose aspirin because you've got a genetic marker that says that's actually irrelevant, cell, for example. So how do you, what's the magic wand there that we get from being to actually treat and chronic disease and make people healthy, as opposed to reimbursement?
I think it's honestly if I had the answer, I would be I don't know, publishing it or doing whatever I can. But I think, one thought on it is that I think it's such a complex and the system we have today, right? is the side effect of an evolutionary business process and incentives process over many layered years of the spaghetti code that's been intertwined. So it's unwinding it and refactoring out the problem is very hard. But I think if there was one thing that I think is almost our original sin that I think was unintentional, but is actually, I think, the broken, the non-marketplace. So it's almost today there's a lot of debate around should we have a single payer health system as a social medicine versus not. I think, and people debate value-based care, et cetera. And I think there's another way to look at it that's, in almost any model, one of the things that first thing I would bet on is a competitive, efficient market where there's a competition for value, where buyers, whether it's individuals or groups, can actually, have sellers compete for higher value, which means lower cost against better results. Like, and I think the heart of that is how insurance, we call insurance, like the transaction model is structured. Like literally that, like I said it tongue in cheek, it's, Bank of America, Visa, and Amazon all in one company, like that being legal, like it's especially the Bank of America, your bank account being the same as your transaction network is a huge antitrust problem. And I think that would be the one place unless they're separated, you cannot, I can't think of a functioning market in that doesn't have that kind of separation. Like if you think of stock market, like equities, Schwab is separate from the NASDAQ, right? Like all these other places where you have like this separation of the custodian of value, the account, from the network that is paid for volume and value that's being exchanged. I think that separation, is deeply fundamental to a functioning market. So if there was one place I would, and then it probably would take like another 50 years for it to wash through, but that would be where I would break it.
So your comment just now about another 50 years, how do we change the time constant for education? How do we change the time constant for education, consumer participation, and roles of consumers and their expectations? We've had telehealth competencies for over 50 years. I go back to the Mass General Logan Airport model. I built NASA's biotechnology program, biomedical engineering, in the 70s. Some of this stuff has been around for decades. So the time constant is one, the last mile is another piece of it. I've heard a lot of good things that you've talked about. So one of the things in your genomics model, I was wondering if you tried to improve the quality of the metadata around patients' early cancer detection. In other words, what's their environmental exposure? What other genetic markers do they have? So we build a database, and it isn't just proprietary to one company like we've got with BRCA and the company in Utah.
Yeah.
So
one comment is actually we've done a lot of work on, for example, when we think about risk models for risk for cancer, and we incorporate. It's actually one thing that we've done is it's not just your genetics, but also lifestyle and health history and family history, etc. But I think back to your kind of time constant, I think it's the question is almost how do you increase the clock speed of the clock cycles of the marketplace, right? So that and I think it is that a competitive market. I've been in Claire's example around what happened during COVID. I think a market thing that happened that enabled that to happen. Because when we tried to work with insurance plans, it was impossible, right? To deliver the care for which they are being paid by the entire country. The reason we're able to do that is because the Departments of Public Health, San Francisco Department of Public Health, CDPH, employers, who are the real payers, were the insurance companies were they were, I don't know if you remember, during COVID, they were absent. They were standing in a corner hoping no one noticed they were there, right? And all the real buyers of care did direct purchasing. So San Francisco was we will pay you, here's a competitive price that we're gonna pay you, and you are on the line, if you don't deliver on a good time scale.
Yeah.
We would
SLAs.
have, when we would have so Stanford, for example, a bunch of hospitals, Stanford, UCF, all relied on us for their employees to be tested all the time. Literally, anytime our lab backed up by a few hours, the Stanford dean would call me up and be should we freak out? It's no, it's okay, right? And it was but that was direct access, right, to a marketplace, and that delivered the form of care that we had never experienced as consumers. And I think that is what a market is, right? And all of us were really hoping that out of COVID, that would be wow, that this a form of healthcare that, and an efficiency of a market that we hope will that should be more of a template that we follow. But it snapped back really, frankly, to be, to the model that needs to be, I think, changed. But I don't know if you,
Yeah, and then I have sort of like my product technology lens in this, which is I think one of the things I like. I tend to be in sort of B2B models, so I haven't done the fun like consumer stuff as much. But I do think that consumer products raise expectations across all surface areas, and so the more that consumers get exposed to on the day-to-day basis, perhaps too much so, to great, easy, fun, accessible, just pure consumer products across the board, the higher the expectations are on things like healthcare, on things like financial services. And so I do think there is going to be this competition for experience that a certain set of buyers are going to really expect. And so I think Amazon's playing for this. They're playing for easy access, Amazon UX, like a price I can rely on. They set the stage with the way they did e-commerce, and then they just brought that model to healthcare. And so I do think you're going to see, and one of the good things out of the pandemic and this like hyper acceleration of telehealth is a lot more consumers have been exposed to what is possible. I now know it's possible that I don't have to do this whole circus to get a swab in my kid's nose. Like, I know it is possible. And I think that knowledge is gonna, hopefully, if the market can become more efficient, it'll result in consumer choice. Consumer choice will fund companies that do things differently. Unfortunately, that market is not always open and accessible, and I think that's the biggest challenge.
So if Rena has like ties into the FTC, call them up.
So I think we'll end it there because they went out here at 9, and then people usually like to network with the speakers and with each other. So we'll leave it at that. And if you have any questions, come up to here. Just before I do that, please come and see me if you want to volunteer for the club, for the digital health track. We're always looking for volunteers. We get to set up exciting events like this and meet wonderful people and have delightful conversations. So come by and sign up.
Thank you.
Thank you so much, guys, for coming.
You two watch me rotate with the rotation of the earth every 5 minutes.
You're processing. You're always so crazy.
Let me just turn it off. I'm recording.
I know.